Good afternoon. I want to thank you all for attending the 4th Annual Cy Frank Legacy Lectureship. I'm Diane Mosier, Professor of Medicine and Associate Dean of Community Engagement and Strategic Partners at the University of Calgary. First, I'd like to do the territorial land acknowledgement. The University of Calgary is located on the traditional lands of the Treaty 7 peoples, which are inclusive of the Blackfoot Confederacy, including the Siksika, Piikani, and Kainai, as well as the Tsuut'ina Nation and the Stoney Nakotas First Nation, inclusive of the Chiniki, Bearspaw, and Wellesley First Nations. And the city of Calgary is also home to the Métis Nation of Alberta in Region 3. That was the most stressful part of the day on my part. We're all here to celebrate Cy Frank's accomplishments, and as many people in the room, he was a very good friend to many of us. We know that Dr. Frank was an orthopedic surgeon, scientist, longtime faculty member in the Cummings School of Medicine, and one of the founders of the McCaig Institute of Bone and Joint Health, as well as the Alberta Bone and Joint Institute. Dr. Frank was internationally known and acclaimed for his visionary efforts to lead and champion the value of multidisciplinary clinical research and the appreciation of this research to innovative solutions in clinical care. At the time of his death in 2015, he was the director and CEO of Alberta Innovates Health Solution. He was known to be an inspiring, empathetic, and wise leader, dedicated to improving the health and well-being of all Albertans and Canadians. The Cy Frank Legacy Lectureship was created to showcase the work of individuals who reflect his passion and commit to health innovation.
It's a huge question to ask about Dr. Frank's contributions because they've been many, they've been varied.
Dr. Frank was very integral in orthopedics in Canada and medicine in general.
His innovation in trying to develop new ways to deliver care was of such a great impact on both Alberta orthopedics and Alberta medicine.
Well, I first met Cy in an interview process for the 13 inaugural scientific directors of the Canadian Institutes of Health Research. Everyone assured me that he was a great leader, a great individual, and a great scientist. Cy and I worked closely together for the next 7 years. Me as president of CIHR and him as one of the 13 scientific directors.
I worked for Cy at Alberta Innovates Health Solutions when he joined 2.5 years ago as the CEO.
One of the lasting legacies for Cy, I think, has been the establishment of this Center for Mobility and Joint Health. The McCaig Institute is a big part of that. And what Cy always believed was the power of putting an engineer together with a clinician to have that collaborative environment.
As a researcher, he had the respect of the entire orthopedic research community throughout the world.
One of the great attributes that Cy had was his ability to put it all together, to form a plan, to get people behind that plan, but then to be able to implement the plan. And that is very, very hard.
Engineering, kinesiology, nursing, rehab medicine, the hard sciences, rheumatology, orthopedic surgery. That was all his vision, and he wanted us all mixed up. He was adamant that we had to be all rubbing shoulders day to day in this multidisciplinary group.
Cy really believed that research could inform better clinical care, but he worked in the real world, and he understood how he had to make changes locally, how he had to make changes provincially, how he had to affect change nationally. And that really earned him a reputation in Canada and beyond as somebody who passionately believed in better clinical care for people.
He had a really strong vision around the value of sharing health information and what that could mean for the improvement of providing services to the patient.
He struggled with some of the injury-related things that many of his patients did, and that helped him, I think, identify with patients.
I think that's what really made him who he was and why he has garnered so much respect is because of that ability to relate to people, no matter their background, no matter where they come from, and be able to bring people together and to share ideas. People felt like he was genuinely interested in what they had to say because he was.
The lectureship is intended to promote and to make sure that those enduring qualities that Cy represented are continued, even now that he isn't with us.
I think he'd say keep going. You know, he leaves behind a real huge number of champions that are trying to make the world a better place, that are trying to make it better for patients and it better for clinicians.
Oh, I got it wrong. I would like now to introduce Dr. John Meddings, Dean of the Cummings School of Medicine.
Thank you, Diane. And I have speaking notes that I'll probably totally avoid, Diane, so you may not know when I'm done. But I was asked just to say a couple of words of welcome, and I'd like to welcome all of you here today to the 4th annual Cy Frank Lecture. And watching that video and thinking about this, I have to say I find it a little hard to believe that this is the 4th year that we've done this. I was a strong supporter of Cy. I was telling our guest speaker here that Cy and I came to this institution not that many years apart, and there weren't that many clinician scientists back then. Cy was an amazing friend. He was a mentor. He was someone that I truly looked up to. Cy had, and I just wanted to tell one little story because I think watching that video, it really brought it home to me. It's utterly true that Cy had an incredible vision that you could make healthcare better by investing in research, and that research was what drives healthcare to be better. But Cy had another incredible ability that I have always been in awe of, and that was that after conversations with Cy, I would often wake up in a cold sweat at 2 in the morning, a week or two later, suddenly realizing that everything that I was doing, and I was certain that I'd come up with the idea myself, had been what Cy had wanted all along. He had this amazing ability to implant ideas in people's minds and to convince them this was the right thing to do. And he had a wonderful skill about it that to this day, I admire, and that was his ability to chat to people to get them on side. And Cy would invite you to one of his GOW meetings that we would often use across the street, and these were his glass of wine meetings. And I finally learned to become quite worried about when I got invited to a GOW meeting, because I was never certain what I was going to be talked into, but I knew I would be talked into something. So I'd like to offer a wonderful, warm welcome to Stefan Lohmander, who has joined us from Sweden today. I think this is a perfect way to honor Cy, to talk about new insights into research and those things that would help our healthcare system. It's what Cy spent his career doing and was utterly wonderful at. And so thank you very much, everybody, for coming. I know this is going to be wonderful. And just back to you, Diane.
So it's my great pleasure to introduce Dr. Stefan Lohmander, this year's Cy Frank Legacy Lecturer. So Stefan Lohmander also is an orthopedic surgeon and a scientist who is passionate about improving patient care by better understanding disease mechanisms, by using reported patient outcomes to evaluate care, and to systematically collecting evidence as a basis for shared decision-making between patients and healthcare professionals. He is currently the senior professor at the Department of Clinical Sciences, Lund, in Lund University in Sweden. Dr. Lohmander received his training in MD and PhD degrees at the Karolinska Institute in Stockholm. After serving as a visiting scientist at the National Institute of Health in Bethesda, Maryland, he moved to Lund where he trained as an orthopedic surgeon and formed a research group of basic and clinical scientists focused on osteoarthritis, notably post-injury osteoarthritis. His previous experience in basic cartilage biology evolved into research on molecular biomarkers for prognosis and monitoring of osteoarthritis. This line of research broadened to include imaging biomarkers and, importantly, complemented with patient-reported outcomes research. With these tools in hand, he then identified and monitored over time patient cohorts with previous joint injury at the risk of osteoarthritis development to better understand the disease. In the course of his work, he identified a lack of evidence to support best treatments for patients with joint injuries, and he performed randomized clinical trials and cohort studies on patients with knee injuries to improve evidence base. I now know that my ACL tear will lead to OA. With more than 400 patients, with more than 400 papers and receiving more than 27,000 citations, he is equally proud of his role as advisor and mentor to a new generation of osteoarthritis researchers, which are inclusive of Per Assenberg, Leif Dahlberg, Ewa Roos, Thorvaldur Ingvarsson, Martin Ungland, and Richard Frobel. The outcomes of research have influenced national and international clinical guidelines and practice for treatment of patients. He is the recipient of many accolades, and also he is a great adventurer. That he is the only person I've knew who's been to Kamchatka, which only the rest of us know because of the risk game we played as children. It is a great privilege to welcome Dr. Stefan Lohmander.
Beautiful, thank you. Thank you, Diane, for your kind words. Let me begin by saying that I'm deeply honored in being invited to be here today to speak in honor of Cy and his legacy. I'm feeling humble in the presence, in his virtual presence, so to say, today. He was a good friend of mine. He was a highly valued colleague, and he was also very much, to me, a role model for what you can accomplish in the best of circumstances. So again, thank you very much for inviting me here today. I was asked to provide a title for my presentation today, and eventually that evolved into what you're looking at, changing the narrative. Progress and challenges to improve osteoarthritis care for more than 4 million Canadians. Now, before I continue into the meat of my presentation, I'll pick up on what Diane mentioned, that one of the really important things in my life as a scientist has been, or is, the people that I've been working with, and I'm working with to a large extent, and these are all my former students and my former mentees, and I count myself as very fortunate to be able to still be working with them. Sometimes they've now been my actual bosses. They've hired me as an advisor, etc. So it's an interesting experience. But anyway, to the extent that I've succeeded in what I've been doing, it's because I've been able to work with these very gifted individuals over a long time. Now, in my presentation, I'll be covering a lot of ground, perhaps. So here are a few signposts. I'll go from speaking or rapid firing a few facts to the issue of sustainability in healthcare and in osteoarthritis care, perhaps specifically, about osteoarthritis and why we get it, and the importance of getting it right the first time. I'll be touching a little bit about the good, the bad, and some of the ugly in osteoarthritis care, and be pointing out that it's not the knowledge that we lack, actually. And finally, coming back to the title of my presentation, Changing the Narrative. So, sit back, enjoy the ride. So here's a warm-up. 1 in 10 Canadians are affected by osteoarthritis, making it roughly 4 million, or at least 4 million. Women, twice as likely as men to have OA, and OA is the cause of more functional limitation and disability than any other chronic disease among the elderly. And I count myself among the elderly, so above retirement age or something like that. And OA is responsible for about 90%, 9 out of 10 cases, for total joint replacement. That's because of OA. And you do in Canada here about 130,000 of these every year. And you do a quick numbers on that, and it turns out that today, as a regular working day, 500 were done. Tomorrow, 500, etc., etc. 2,500 per week, 10,000 per month, 130,000 roughly per year. These are big numbers with regards to patients and healthcare production, and of course Canadian dollars. And these numbers will continue to rise. And I will talk a little bit about the reasons for that. And the costs will continue to rise. In the US, the total joint replacement costs represent $1 out of every 1,000 GDP, not healthcare budget, GDP, gross domestic budget. This is a huge number, truly. So this is big stuff, important. Every second Canadian with osteoarthritis reports moderate to severe pain, meaning that these individuals consume analgesics for painkillers for their osteoarthritis. Another thing that I'll be coming back to. OA patients often have comorbidities in the form of cardiovascular disease, diabetes, obesity, and a few other things, depression not to be forgotten. And osteoarthritis is moreover associated with excess mortality. You would think that you don't die from osteoarthritis. You actually do. The risk increases between 1.3, 1.4, somewhere around there. Now, about costs. In rich countries, costs of healthcare are rising faster than economic growth. That's a fact. In Alberta, in Ontario, that's the public sector per capita health expenditure by use of funds in current dollars between 1975 and 2018. It's increasing, right? And quite dramatically so over time. That's per capita health expenditure, public sector, which means it doesn't include every dollar probably, but lots of dollars still. And I'm not sure what the GDP in Alberta has looked like over these years, but it's something to behold. In that perspective, let me introduce the word sustainable, meaning able to be maintained at a certain level, able to be upheld or defended, and you can put many kind of interpretations into this term. For me, it's an issue about resource consumption. Can we really maintain this consumption of resources, this increasing number of joint replacements into the future? Is that really possible? But also with regards to ethics of doing the right thing. Can we continue to do what we're doing? Are we doing the right thing? Are we getting it right first time in treating our osteoarthritis patients? I'll have a few comments about that in the next few minutes. So there is obviously from the healthcare funding resources an increasing focus on health for the dollar. So that means, in my view of the world, in my view of the real world, that we need to eliminate low-value interventions and practices in what we're doing. Otherwise, there will be no room in the future to introduce new and better things. If we continue all the low-value stuff, where will we get the dollars to pay for the new things we want to introduce? So, having said all these things, now a couple of words about osteoarthritis, the disease I'm speaking about today. This is perhaps the image that I had when I started getting interested in osteoarthritis, and perhaps the image most people have when they sort of image an OA patient. It's an old lady, an old man perhaps, with sticks and, getting around, but having a bit of a problem, and sometimes doing reasonably well, as this lady does. She's obviously been out picking up the morning paper in her letterbox out in the countryside somewhere. And she's getting around. She's got knee OA, at least on the right side. She's got Heberden's nose and probably a bit of else as well. And she does have pain. She does have loss of function. She does have impairment. She does have loss of participation. She's not able to get around and visit her friends anymore. She's not able to use her bike, etc. So she's getting isolated. She may be getting depressed a bit in the future, and she may not be able to stay in her home out in the country because she's not able to kind of care for herself anymore because of these issues. So that's perhaps our image of the classic OA patients. And yes, there are these OA patients, but this is also an OA patient, if not today, tomorrow. Because obesity is one of the more important reasons for why we get osteoarthritis. And sports injuries, yes, either among the professionals, like this one playing in LA Galaxy, or perhaps in the young ladies or young boys playing soccer in the junior league, the junior league, and that's also a cause of knee injuries that might lead to osteoarthritis of the knee. Other sports, more or less local here, I guess, may also lead to injuries that lead to yes, osteoarthritis of the knee. And if you're in the military, by the way, the leading cause of early retirement from your active duty in the military is, you guess it, osteoarthritis. And often because of knee injuries in active duty. And of course also some professions that include hard work, hard physical work, accidents, etc. So why do we get OA? Quickly summarized into what I just said. Because of age, yes, and that's an interesting factor we could discuss, but I won't because it'll take too much time. Our parents, what the genes we inherit, is about half of our individual risk. And perhaps most importantly today, lifestyle. Diet and exercise leading to obesity and various other things. Use and abuse of joints at work and leisure. And these are modifiable, these later factors, meaning this could actually be the target of prevention efforts, which we do too little of today, by the way. Now, how do we best manage osteoarthritis? And I would say again simply by getting it right the first time. So what are the tools we use in managing osteoarthritis today? What are the tools that we recommend? I would say that there are 3 pillars, so to say, in there. It's the non-pharmacological, non-surgical management, where the main and most important part is actually exercise, getting active, using your joints. And then, of course, we have painkillers of various kinds, and we have surgery. These are the 3 pillars. And in those, among those, in there is the good, there is the bad, and there is some ugly as well, actually. I usually present these 3 pillars actually as a pyramid, where the platform, where the basis of the pyramid is education, exercise, weight loss, self-management, and that's for everyone, irrespective of the stage of the disease, irrespective of how much of a problem you have. That's actually helpful for everyone, for in a very large proportion of those with osteoarthritis, irrespective of actually the stage of your condition. But it's not a treatment or management that's helpful for everyone all the way, so to say. Many actually needs some additional means of decreasing the pain, using walking aids, using painkillers, using drugs of various kinds. And some eventually will need surgery. And you'll notice the little area covered by surgery up there, that's mainly joint replacements, and I said that's 130,000. So then imagine what number of people are at the lower levels in that pyramid and actually manage quite well, thank you, with these means of managing the condition. while every year 130,000 of them, so to say, migrate up to the top of that pyramid. So these are big, big numbers in the Canadian society and in all societies, by the way, not just the developed societies. Osteoarthritis is becoming a really big problem in many of the countries that we used to call developing countries, but are now often further along than that. So exercise, I'm borrowing a slide from my friend Eva, is an effective osteoarthritis drug. But the full potential of an exercise program requires at least a dozen focused, supervised, progressed exercise sessions over at least 6 weeks. So this is not something you kind of, as a health professional, with a wave of the hand, tell the patient you should exercise a bit. That's not going to be very helpful. You need to send your patient to your physio usually, and to get the patient into a program that includes education about what the condition is about, how we deal with it, and what the usual prognosis is, and then into an exercise program, often group-based, but it could be otherwise. That is helpful. We have good evidence for that. We don't really need to do any more clinical trials. We know this works. And ideally, of course, we should be taking something like 10,000 steps a day. We don't usually, but let's say we should. But any number greater than we're doing now is usually better than what we are doing today. So whatever small increments you can do in increasing your physical activity, just walking or running or whatever you can do, is actually helpful in this context. Now, the gains we could make if we were able to do this are quite amazing, actually. I'm here quoting or summarizing some results published by Elena Lucina from Boston, just published recently a few weeks ago in an American journal. And she to summarize her data, is in the US, there are 14 million people living with knee osteoarthritis. Half of them are not physically active, period, not physically active, essentially zero. If 1 in 5 of those, just 20% of those who are inactive, actually would become inactive at a reasonable level, at a recommended level, that would save approximately 900,000 QALYs, quality adjusted life years, which may be a little bit abstract for most of us, but converted into something else, this would actually prevent 100,000 cases of cancer, 200,000 cases of cardiovascular disease, and 200,000 cases of diabetes, in addition to improving the osteoarthritis of the knees of these individuals. And that should make an impression on us, I think, on the importance of actually at the population level doing something about the too low level of activity, maybe not in Calgary, but elsewhere in the world, and the healthcare resources we could save if we would be able to accomplish that. Now, that's a lovely prognosis of what might happen, but this obviously is more like reality today, as we all are aware of. So what can we do to improve things in the real world when the real world looks like this? Well, in Scandinavia, in Sweden and in Denmark, we looked at numbers like that and the real life situation. And in Sweden, some 10 years ago approximately, something called Better Management of Patients with Osteoarthritis, BOA in abbreviation, was developed. It's a program where physiotherapists are educated that then educate patients about osteoarthritis, about how to deal with it in daily life, and gets the patients into an exercise program, a structured exercise program again. Now we've trained more than 4,000 physiotherapists, more than 700 primary care clinics in the country are involved. 120,000 patients have been through this program over the years. Does this mean that we've succeeded, everything is fine? No, we're not able to reach the whole population or the whole OA population, but we're reaching at least some of them, and far better than we were able to before. In Denmark, Eva Roos and Søren Skue used the BOA as their platform and then improved it and made it better, and have introduced both in Denmark and in many other countries around the world, including Canada, including Alberta, where the GLAD program, Good Life with Osteoarthritis in Denmark, GLAD, is introduced. And that's a two-day course for physios and other professions, whatever have you, chiropractors, etc. are welcome. MDs are welcome as well. And that's an 8-week education and supervised neuromuscular exercise programs for patients with knee or hip OA. And there is an evaluation built into the program where data from these patients are fed into a database so we know what's going on. And if the physios and the patients don't deliver, we chase them for their data. And we know from both the BOA and the GLAD programs that the patients experience less pain, better function, increased physical activity. There are fewer on sick leave and fewer taking painkillers as a result of these programs. This is low cost, high value care actually for osteoarthritis. This is one of the good things. There are also in development or having been developed actually now mobile phone apps, cell phone apps that will essentially deliver the program on a one-on-one basis if you prefer that kind of program. Some do, some don't. So it is a nice complement to the face-to-face programs of GLAD and BOA. Now, some patients will need, either in that exercise program, a bit of help with the pain, or everyday help with the pain, perhaps. So what do we offer? What do we recommend in the way of drugs for osteoarthritis? Well, we have recommended, so have I, paracetamol or acetaminophen for many years. But we know now from additional trials, more recent trials, that the effect against OA pain is actually pretty minimal. There is an increased understanding of the risk of accidental and intentional overdosing. There is a problem with liver toxicity. And the utility for OA pain, as I mentioned, is actually questionable. So that's actually dropping off from the list gradually in most countries now, following the international recommendations. Non-steroidal anti-inflammatory drugs, your diclofenac, Voltaren, your naproxen, or ibuprofen, or whatever it might be called, are recommended together with the sort of subclass of them, the COX-2 specific inhibitors. And we now recommend as the first choice with these the topical creams, especially for knee osteoarthritis care. And the second choice, when that's not possible or doesn't really work that well for the individual, well, it's a bit problematic for the hip, for example, obviously. The second choice would be oral, but with care for those with high blood pressure, heart problems, GI conditions. And if you remember what I said earlier on, a very high proportion of patients with osteoarthritis actually have exactly these problems, which should make the GP or whoever is writing the prescription pause for a moment and consider, is this the right thing? At least for an oral medication. These are very commonly prescribed. Like 2 out of 3 patients with osteoarthritis take these drugs. They don't always work. The effect size for those who are interested in those numbers is about 0.3, which is modest in my world. It works, but you know, so. So are there stronger pain medications? Well, such as opioids, for example, now obviously being discussed quite extensively, if they are the right thing or not to use. In relation to osteoarthritis, I think the question is fair. Are they, as they call, stronger pain medications or not? Well, let's look at the evidence. This is a series of forest plots, 3 panels with 3 different plots. And where you can see on the left of these panels, there are names and years. These are the clinical trials being published on NSAIDs in the top one, weak opioids in the middle, and the strong opioids down at the bottom against osteoarthritis pain in osteoarthritis patients. And each of the trials, the result is shown by the blue dot and the horizontal line there showing the confidence interval. And the average for each group is circled there by me with red. And as you can see, the red symbols or the circle symbols are right above each other, meaning that the NSAIDs, the weak opioids, the strong opioids, are similar in their effectiveness against osteoarthritis pain. There is no difference. Opioids are not stronger pain medications for osteoarthritis than plain old NSAIDs, your ibuprofen or whatever have you. They are not stronger pain medications. Repeat that after me. And this is really, really important. I'll come to that in a moment or two. So NSAIDs and opioids offer similar pain relief in OA patients. So why would you prescribe an opioid to an OA patient? I don't know, honestly. And in Canada, as in the rest of the world, you have this problem. This is a slide from a presentation by your Deputy Minister for Health in May this year for the OECD. And it gives you a few numbers. In Canada, the number of opioid-related deaths on all kinds of people, of course, from opioids between January 2016 and September 2018, that's 2.5 years, let's say. That's 10,000 plus. Compared to the number of patients dying from HIV/AIDS, that's about the same number, but note that's for 12 years for HIV/AIDS and 2.5 years for opioids. I'll let that sink in for a moment. And we know if you go down to the country below here somewhere, it's 10 times as big. 100,000 people dying every year from this. This is a bloody disaster. Excuse the language, but it is. And we have a problem in Sweden as well. Not these large numbers because we're fewer people, but we have the same problem everywhere. So what is going on, and why is this of relevance to what I'm talking about today? Well, do you remember that I said that osteoarthritis patients, half of them at least, or 2/3 of them have really significant pain, so they consume painkillers. So we, as doctors, have gotten into the habit of prescribing opioids for many of them because we were not aware of the fact that they are not more effective than sort of an ordinary over-the-counter NSAID. Marketing probably has something to do with that. Now, these overdose deaths that I showed on this past slide obviously are not in the majority from prescription drugs. No, they are from illegal drugs, fentanyl and other synthetic analogs. Of course they are. But we know there is a significant proportion, number of patients being started into opioids by doctors, such as me, such as you, some of you. And it's not just those that get the prescriptions that actually are in trouble. It's the families of those who are being prescribed these drugs. So in the families where a family member has gotten an opioid prescription, there is an increased risk of dying from an overdose, threefold increased risk among the family members. And there is a good dose relationship. The more opioids prescribed, the stronger they are, the higher is the risk, up to 15-fold increased risk in those families where one of the members got an opioid prescription. And I'm not talking now about opioids in cancer, opioids in certain other situations. We need them there, but we don't need them in osteoarthritis. And here, coming back to something close to home for me, a publication just coming out in JAMA, Journal of the American Medical Association, a few months ago, or even less, comparing opioid prescription after surgery in the US, in Canada, in Sweden. I can't say much about cholecystectomy or appendectomy or breast excision, but I do know a few things about knee meniscectomy or not. Knee meniscectomy is done by keyhole surgery. the incision is about this size, 2 or 3 of them, and the meniscus itself isn't really, doesn't really have any nerves. And in Canada, in the US, 80% of those patients are given prescriptions for an opioid. And I'm shaking my head and thinking, what in the world is going on? This is total crazy. Absolute madness. And I would even, discuss or consider the, 10% or something in the Swedish healthcare system as being too high. This is trivial surgery as surgery goes, and there is no reason to prescribe opioids at that rate. Clearly not. This is bad medicine. This is really one of the uglies. The reasons for this, well, marketing, I'm sure, is some of the explanation. This is an ad from 1901, and I think you will recognize the label on that vial, and promoting the beneficial effects of using that in a number of situations. This ad here is a bit more recent, perhaps 60 or 70 years ago, 1950s or something, could it be? I don't know, somewhere around there. And well, I'll let you consider the design of that ad and what it really means, what it meant at this time. And I would say that yes, marketing is perhaps a bit more sophisticated today, but no less powerful. There is a reason why doctors starting prescribing opioids for osteoarthritis and other fairly trivial pain conditions. And that's because of marketing. And we all know what's going on now in the courts and wherever else. And I think we as physicians, as doctors, share some of the guilt in what's been going on. We can't blame it all on the marketing. We actually held the pen that wrote the prescription. And we need to do something about that and do it quickly and stop prescribing opioids for meniscectomies and whatever else we might think of. So going to something else, let's move up and have a look at surgery. And I'll just pick one form of surgery that has been for many years the most frequently typed form of surgery in orthopedic surgery, actually all over, and in particular for osteoarthritis. That's been the arthroscopic surgery for the painful knee of the middle-aged or older patient. And middle-aged, I would say, would be starting around 45 or something like that and up. And that's the majority of those patients who've had a meniscal surgery, and the minority that have meniscal surgery are the young, active athletes and whatever that get a meniscus tear at the sports field. That's not what I'm talking about. I'm talking about this particular group of individuals. In the US, at least 500,000 of these were done every year, and I'm sure that the numbers correspond to what's being done in Canada as well, if you look at the population. Now, in that particular procedure is actually now being tried and tested. It's I would argue, the most well-examined orthopedic procedure all over in clinical trials, randomized clinical trials. This is another of those forest plot. What it is it's a cumulative forest plot, meaning that up at the top there in 1993, the first ever trial was done. And then in 2002, an important trial that compared actually the procedure with sham surgery, as we surgeons might call it, but placebo surgery, pretending we did the surgery to the patient, but actually not doing it. And he showed that the benefit for the real surgery was really minimal. And if you can see vertically along this series of clinical trials up to the very last one here in 2018, nothing much changed. The result, if you compare to the zero line that's going vertical, is more or less the same in every trial. What's happened is that the uncertainty level, this horizontal bar is getting narrower and narrower for each trial because we add more patients to the analysis, so we get more and more certain of the results. And yes, it shows that there is a benefit for the real surgery as compared to placebo surgery, as compared to exercise, as compared to care as usual, etc. Sure, I acknowledge that, but there is a but. The advantage corresponds to about 3 millimeters on a 100 millimeter scale of pain. meaning that a clinical relevant benefit should be at least 15 millimeters in this particular situation. So this is a trivial benefit for a surgical intervention that's costly, that doesn't carry a high risk, but that does carry some risk. If 1 in 1,000 patients actually dies from this, this means that quite a number of patients would die each year in this country because of a trivial surgical intervention that's not really worth doing, and that's costly. So the conclusion from this series of trials, they all show the same thing, is that lifestyle modification and exercise are as effective as arthroscopic surgery in managing the painful knee in the middle-aged and older patients. Most of these patients have actually earlier or sort of mean average stages of osteoarthritis in their knee, and their meniscus is not the problem. Now, claiming this and trying to get this message out is swimming upstream. And there is obviously a large number of orthopedic surgeons out there, the diehards, who say, well, my patients, I know that my patients actually get a lot better from this intervention. So my patients must not be in these trials. And those that have mechanical symptoms, sort of where the knee sort of gets locked or catches, etc., the outcome for those is much better. And they claim this rather forcefully, and trying to get the message out is not easy and can be quite difficult sometimes. My response here today is no, they don't. And we have a whole series of studies published that will confirm what I'm saying. Patients with mechanical symptoms do not have a better results than the average of this intervention. We know that. There is a large number of studies that have shown that, and there is no study that proves the opposite. So, in addition to this, and let me say this, being an orthopedic surgeon myself, that I am limited in my ability to actually predict what treatment is best for these individuals. I'm not one of the 194 there in this actually trial study being done by orthopedic surgeons, published by orthopedic surgeons themselves, which tested on these 194 surgeons 20 patient profiles from a clinical trial and asked them to predict, what treatment is right for this one and what will the outcome be. And the result was that their predictions were similar to predictions expected by chance. So I am, as a surgeon, orthopedic surgeon, is not better in predicting the outcome of arthroscopic surgery than my cousin the gorilla. So again, saying we shouldn't be doing that kind of surgery. It's not the thing we should be doing. This is low-value care that we really should cut down to a very low level, if at all, in this patient category for these kinds of problems. I'm not saying arthroscopic surgery as a whole is worthless, but for this particular patient category, the numbers really speak forcefully against continued use. So why is it so difficult to get this through? Well, it's because orthopedic surgeons, believe it or not, are also humans, because we have the same problems as anyone does. We are prone to confirmation bias, cognitive dissonance, and we are biased by vested interests in industry and marketing and whatnot. So we react like everyone else, when we're being told that what we do is wrong. We say, I don't believe you, etc. And I'll just continue what I'm doing because I know it's right. And how much evidence, how many trials do we need to publish for, the last ones to abandon ship? Tell me. And I would say it's not knowledge that we lack. What is missing is the courage to understand what we know and draw the conclusions of what we know. That's what we're not doing as surgeons, at least in some cases. On a more positive note, of course, total joint replacement is for the right patient with the right surgery at the right time a really magnificent, a fantastic surgical intervention for osteoarthritis patients, for the majority of them. This really is effective surgery. It's expensive, it's resource consuming, etc. But for those with severe symptoms and where nothing else has helped, this is really the thing. However, there is always a however. About 2 out of 10 patients are not satisfied with a joint replacement for osteoarthritis. And this is a problem because we've done 500 of these today, and 100 of those will not be satisfied. And it's not like in rheumatology where you can switch a patient to another drug. If you've done your surgery, you've done the surgery, and there is no sort of undoing surgery. So this is a bit of a challenge, and it's fantastic for those 8 out of 10, but not so fantastic for the 2 out of 10. And we need to get smarter in being able to select, being able to identify before the surgery those which really will not, in all likelihood, benefit from the surgery, and figure out how can we help these individuals instead. Not just saying, go away, we're not able to help you, but how can we help them with some other means of managing their problem. And there we need more research, we need to get smarter. And as I mentioned, knee replacements keep going up and up and up. And Canadian data, the yellow curve there is, the yellow line is essentially following all the others, going up and up and up. And how long are we going to be able to continue that? Trying to summarize some of what I said, I would say we need to eliminate low-value care. We need to deliver high-value care, and we need to get it right first time. And coming back to my title slide, we need to change the narrative. What do I mean by that? And I'll quote a small editorial that I co-wrote with other investigators in different countries, saying we need to change the message. Knee pain is a modifiable symptom related to sensitized knee structures, influenced by many factors rather than solely related to damaged joint structures. Following that, of course, we need to change the treatment focus and acknowledge that the focus should not be on the structural damage model. We look at the x-rays, and I do that as a surgeon, of course, but if the patient is not sort of lined up for surgery, I would rather forgo the x-ray. It doesn't mean anything to the patient. What means something to the patient is actually the symptoms, the problems caused by the symptoms. And many patients with quite severe structural changes do not have any significant symptoms. So why are we bothering about doing an x-ray on these patients out in primary care level, for example? Don't. I'm saying don't do an x-ray, don't do any imaging. It's the important things are the symptoms. And we need to put the patient in charge. As clinicians, we should engage in person-centered care while coaching patients towards self-management. If we do that, I think that we can have an increased number of patients who can actually live well, reasonably well with their osteoarthritis. If we help them, if we support their lifestyle changes with exercise, weight loss, self-management programs. And for Caroline, obviously, there will also need to be a bit of prevention in there and a more of an emphasis on that. And I'll give you that, Caroline. It's not my area of expertise, so I'm not daring to move into that. I'll leave that for you. But anyway, we need the prevention. And I mentioned that early on because we do know some of the most important risk factors. We can deal with them, not easily, but we can. And using the tools that I've promoted here, we can help patients live well with osteoarthritis. And then there will always be a proportion left over for us orthopedic surgeons to help with joint replacements or other types of surgery for the osteoarthritis. And that needs to be there. That's part of the package, of course. But I think that's a sort of a summary. And I would say, as my words of wisdom for you, it's not about decreasing osteoarthritis. It's actually about decreasing the burden of osteoarthritis. I don't care what the joint looks like on an imaging or whatever else you might do, but I do care what the symptoms, what the problems of the patients are. That's really our focus and should be our focus. Thank you very much.
Thank you very much, Dr. Lohmander, for your very clear message and insightful talk. We're able to take questions now. There's someone with a microphone who will come to you with the microphone if you have a question. Are there any questions from the audience? I'll ask the first one then. One of the big, so we have, you see a patient and you're prescribing exercise, but they have 100 barriers as to why they cannot or will not consider exercise. How do we actually implement an exercise program? How do we get beyond those barriers?
I think you should ask one of the physios here. But anyway, I'll give you my 5 cents. It's important to explain to the patient that it's not dangerous to increase the exercise. I mean, many people think about osteoarthritis as a wear and tear disease, and they might even have been told by some other doctor that your knee is worn out. And then someone tells you, you should start getting active. You should, do exercise. It's hard to kind of fit that together, of course. But we should tell the patient that actually doing exercise is not dangerous for your joint. It's actually good for your joint. It is good for your joint. It's good for all the tissues in your joint, including any cartilage and whatever that's left in that diseased joint. So, and the second thing is, it'll hurt in the beginning, especially in the beginning of the sort of stepping up of the structured exercise program where you kind of increase the activity with time maybe. And you should tell the patient that, and that's all right. It's not dangerous. It is something that's normal in this situation. You can take a painkiller or something if you know that you're getting pain from the exercise. Continue doing it. And eventually, after a few weeks, you will find out that exercise actually helps.
Thank you. Deborah, and up there. Oh, you've got a question here. Sorry, this one to the left first. Go ahead.
Is arthritis a sudden affair? I can speak personally. In recent times, I would say over the last month, I've been having pain in my hands. The doctor says arthritis. I don't know how he came by that decision, but I don't know if it is associated with trigger finger. Is arthritis and trigger finger related?
Not directly. We know sort of you can have the two things at the same time, of course, but generally speaking, I would say these are two different conditions, but they are both associated sometimes with increasing age and some degenerative processes in the tendons or in the joints respectively.
This was sudden, as if I hurt it.
Yes. Both conditions actually you will benefit from doing exercises, and obviously there are special exercises for hand osteoarthritis.
Not ready for the night,
Only you can tell that. Only you can tell me. I can't tell you. You can tell me. Are you ready for the knife?
Deborah had a question at the top left.
Thank you. Thank you, first of all, for a fantastic presentation. So I think all of us are challenged in a very big way with implementation and uptake. And so can you suggest where we might best invest our energies and efforts in order to improve the uptake of knowledge that is out there in order to achieve your your lofty goal here that you've described in your whole presentation in terms of managing OA better, given what we know already?
I can give you some ideas, obviously, and some thoughts, but I don't have any magic, one to say this will fix it. I would say, let's think back like, 50, 60 years. You saw that smoking ad there in one of these slides. It took, 50 years from the time when the scientists first identified, smoking causes cancer and lots of other things. And now finally, I think it's making an impact on the society level. And I think we may be looking at the same sort of thing when it comes to one of the major risk factors for osteoarthritis, obesity, and another risk factor, lack of physical activity. I think we need a long-term perspective, and we need population health perspectives, and that obviously is not my forte, not my area. But I would say that the programs that we've tested out in Scandinavia, the BOA and the GLAD programs, are showing at least a little bit of a direction of which to go. It won't solve the whole problem, obviously not, but it will solve some of the problem. And the GLAD, for example, is being introduced now in Canada. It's being introduced in New Zealand, in Australia, in the UK, in Norway, in China. I don't know how many billion people live there. And there is another situation, someone tells them exercise, and they exercise. In contrast to some other societies, and they have the traditional Tai Chi and other forms of exercise, if I can use that term, that actually are part of their culture. So I think the smart people can do things, and I think we need to apply these kinds of ideas to this really huge problem, because it's not a question of continuing with care as usual. That's not sustainable. If I look at the reports from the US, where they project the increase in the number of needed joint replacements in the next, say, 20 years, that need exceeds the number of orthopedic surgeons possible to train in that time. Who's going to do the replacements? I don't know.
Nick?
I have a question for you. So first of all, I enjoy provocative talks, and I think I was provoked in more than one way because I resemble a lot of your remarks as an orthopedic surgeon that does meniscectomies.
I know, because we've had a chat this afternoon. So.
But what do we do when the evidence fails? What do we do with all the people on the other side of the forest plot? And what do we do for people who didn't enter into those trials? Because talking to some of those authors, we know that they struggled to complete those trials. So there are a lot of people out there. And part of this question relates to the fact that part of my Cy Frank's legacy for me is he did an arthroscopic partial meniscectomy in my knee, and I benefited greatly from it.
Might that be because Cy did it? No, a more serious response. Surely, we should not take the result of one trial or a couple of trials, maybe, which might in addition be rather small trials, as a reason to change policy completely. I agree. But now we have more than 10 trials, and they are monotonous in their outcome. They all show the same thing. We can't ignore that. And secondly, we have an intervention, a surgical intervention that doesn't work, sort of on the average doesn't work. And then the obvious argument is, and I'm entertaining that as well, there must be subgroups actually in there that benefit. That's kind of a logical suggestion. But then we've actually tried to find those subgroups by doing analyses of many of these different trials, trying to identify subgroups. We've not been able to find any. We've done observational, fairly large studies of, say, 1,000 patients having had this intervention, and then follow them over time after the intervention and trying to identify and compare the outcome. Some are much better, some are a little better. Is there anything that predicts that someone will get much better? No, we can't identify any subgroups, any predictors of outcome in these studies. So that's my first argument. My second argument is we have a surgical procedure that doesn't work, essentially. Sorry. For that group of people. I'm only talking about that group of people. I'm only talking about that group of people. That's the great majority. That's about 80% of those that have this kind of intervention are the people I'm talking about. I'm not talking about the 20%, the young, etc. Young athletic ones. Yeah, like Nick. Like Nick. Now, this intervention doesn't work, and then you say you've tried everything else for these patients, and there are some for where everything else didn't work. And now you're telling me you're going to go provide them, or you're going to submit them to a procedure that we know doesn't work. Where's the logic in that? Does the procedure become better because patients have failed on everything else? I would rather say that makes me worried. If someone has, had 3 or 4 different kinds of interventions and nothing works, that's a bit of a warning flag to me as a surgeon. I would be hesitant to do surgery on that patient without a very strong reason. And a patient having failed everything earlier does not make the surgery more effective. Anybody against? No, thank you.
Dr. Ronsky.
Thank you. Stefan, I'm over here. Thanks very much for a very provocative and also thoughtful talk. I was interested in your thoughts about the exercise, and what's going through my head is, what is the state of the knowledge and your thoughts about if we have sufficient knowledge about how much exercise is enough, how much is too much, especially in the age where we've got wearable devices and people are counting everything and wanting to hit a certain set number, and we know that that's not good for everyone potentially.
Well, again, let me confess the obvious. I'm not a physiotherapist. I'm not an exercise specialist by any means. I do work with some that I think are that. And what I'm told is that, yes, you do need a certain dose for the exercise to become effective. And you may go beyond that and overdo it, but I think that's probably in part linked to the individual patient, what sort of physiology you have and what the condition of your knee joint is. And to me, that's at this time rather difficult to predict, certainly on an individual basis. But I'm sure there is an optimum window in there, which I think you need to figure out actually what is that window. And secondly, I would add to your question, what are the mechanisms behind the beneficial effects? Is this really a specific effect? You're strengthening the force or the increasing the strength of this muscle or that muscle or whatever? Or is it a general physiological effect? Does the brain actually work does the exercise work at the brain level? Sorry, getting a bit fuzzy about this time of the day. Does the exercise actually work on sort of the pain signaling level, either distal, peripheral, or central here in the spine or up in the brain? I don't know, but I'm thinking, looking at much of the data, that at least some of the effects, some of the benefits of the exercise that we observe is sort of a systems level effect and not specific on the joint.
So Janet Yale.
Thank you. Over here. Hi, for those of you who don't know me, I'm the president of the Arthritis Society, and certainly support a lot of what you talked about in terms of the three pillars being both non-pharmacological, pharmacological, and of course surgery. On the pharmacological front, for many of the patients we hear from, pain management for chronic pain is an ongoing issue. And certainly very supportive of the comments you made around opioids not being a good solution for chronic pain management. But one of the things that I'm a bit surprised you didn't talk about is the potential for cannabinoids in the context of pain management. And certainly medical cannabis is something that while we don't necessarily have robust evidence yet that would support it, but certainly in Canada and certainly for patients that we deal with on an ongoing basis, the need for pharmacological solutions that are sustainable and hopefully not harmful is something that you didn't talk about, and I wondered if you have any comments about that.
I'm well aware of the activities, so to say, in the cannabis or cannabinoid field. I'm also aware that there is actually at this time very little evidence to support a policy one way or the other, on the official level at least. I've participated in all the international guidelines for osteoarthritis from the Osteoarthritis Research Society, and the most recent one came out a couple of months ago. And when we collected the evidence for that, for the sort of which were the basis for our recommendations, we were unable to find enough evidence on cannabis or cannabinoids to make any recommendation at all, either for or against. We're just noting we need better data, and I would really hope that better data is being generated, that legit clinical trials, and we do need, the formal trials to do this. The problem, of course, with that is who's going to pay for those trials? Industry is not going to pay for them because, they can't make any money from growing pot. And others do, but not the big pharma, who know how to do these kinds of trials. So it would be the CIHR or the NIH or whoever, they would probably have to cough up the money to generate the evidence for or against. But I agree with you, we dearly need something in addition to what's left. When I started in this field, we had a bit of a range of different pharmacological choices, and it's actually been shrinking over the last few years, and almost only NSAIDs being left, and that's obviously a problem, as I try to indicate. So I agree with you, but I can't say for or against.
So we'll take two more questions. There's one to my left here.
Hi, I'm June Bergman. I'm a family physician here in town, and I've been working in recent years in the area of chronic pain. My question really is around the silos of information that I think I've really appreciated your discussion. I've loved some of the comments you've made. There's another whole silo of information and evidence in the area of chronic pain. And it seems to me, in the light of the way I think that we would all be thinking, some kind of a partnership between those two silos of information that would allow us to better understand many of the questions that you're leaving unanswered. Why does it work in one person and not another? There's a fair amount of evidence around chronic pain, why it's different in other people. We're not all the way there, but it's very much, I think, worth a partnership, and I'd like your comments on that.
Well, being an orthopedic surgeon, I'm obviously of a silo mind, but doing my best to step out of that in the later phases of my career. I agree with you. We have a problem with silos. And, you know, we've tended to think that OA pain is something special. It's not. I think it's a chronic pain. I think that's the important part of it is that it's chronic. And we know that chronic pain actually makes lots of things happen in your body, in your signaling systems, so to say, going from the knee joint to your spinal column and all the way up to your brain. Things happen. The brain restructures in the presence of chronic pain. Things happen, and we need to understand those better. And I think that we, in this particular musculoskeletal field, need to partner with other colleagues who look at other aspects of chronic pain and we learn from each other. Absolutely, I'm with you.
Thank you. And our last question here.
Okay, I'm thinking of it from the exercise perspective. So it's good to hear all of that because I'm a Pilates instructor and hopefully future physiotherapist. I noticed there's a lot focusing on just knee and hip. Is there anything into the ankle and other joints that are impacted? So that's sort of my first question. And then I'm really excited to hear about the GLAD. Do we know when that will be in Canada, and will it be available to other health professionals? Mm-hmm. Do you have to be a physio or whatever? Can somebody that has advanced Pilates training or RMT or whatever get into those?
Mm-hmm. Okay. Well, firstly, what about treating OA in other joints? Well, the reason why I focus on knee and hips is because that's probably like 90% of what we deal with in clinical practice. And the knee is the really big thing. But yes, ankle osteoarthritis happens, but it's surprising how bad you need to be to your ankle in order to cause osteoarthritis as compared to the knee, for example. So we do see ankle osteoarthritis or midfoot osteoarthritis and very other types of osteoarthritis in the foot. But it's really uncommon in comparison with others. So I can't say much other than, yes, we do have various options to deal with that as surgeons, but otherwise I'm really quite ignorant, I have to confess. But the exercise programs that I mentioned, the GLAD primarily, which I think is the best one currently, is getting to be available in Canada. I know there are efforts to get it up and going in Canada as we speak. Some others here local can say more about that. And I think that's a good thing. It's not going to solve all your problems, but it's going to improve things a bit, and I think it shows sort of the direction in which to go.
Thank you. There are many sites in Canada, so you can just look up under GLAD Canada, and it lists all of the sites. Yep. Yes. So I think that we'll draw this part to a conclusion. And again, I want to thank you, Dr. Lohmander. And on behalf of the Advisor Committee, the McCaig Institute, the University of Calgary, and Alberta Innovates, a token of our appreciation.
Thank you.
I would also like to thank the friends, family, and colleagues of Dr. Cy Frank who have contributed to the Cy Frank Legacy Lectureship Endowment, as well as all of you attending today. And lastly, we continue to welcome any donations so we can carry on having these wonderful lectures. And now, if anyone would like to join us, by Hippocrates downstairs, there will be wine and cheese. Thank you.
I know you need to leave. No worries. It's all good. Thank you for your help.
Well, good. Now you're on.
Yeah.
We take it from here.
6:30. And does he have a ride for dinner?
He does have a ride. Was it 6:30 or 7?
For me?
What was it?
6:30. On mine, it's 6:30.
Oh, okay.
Probably yak for a while and then get dinner going.
Yeah. Yeah. Go have a glass of wine.
One glass of wine.
Just one. We're gonna have to take a wine.